These are my disclosures, which the one on the previous page about being co-chair of ASR is probably the most important one, right? So probably isn't too hard an argument to get people to understand that we're going to really have a need to prove value for spine surgery. Degenerative spine disease is the biggest bucket, right? There's huge amounts of overall cost, lots of surgeries that we do that are often very expensive, in particular the growth in lumbar fusion. A lot of what we're talking about today touches on deformity, and deformity surgery has grown as well and is by and large even more expensive than degenerative surgery. So my perspective on this really started back about 15 years ago. It was a time when CMS was threatening just not to pay for fusions at all, and there was a big uproar, as you can imagine, among societies and industry and spine surgeons, a concern about that. And Dan Resnick, who you can see here, and I had the opportunity to spend a fair amount of time down in Baltimore and Washington talking to CMS about why spine surgery was really worthwhile and the fusion was worthwhile and that they shouldn't stop paying for it. And they said a number of things to us, some of which I anticipated, but some of which I really didn't anticipate. So firstly, they said, your data sucks. They were pretty clear on that. They published it in an article in Spine, and that wasn't surprising because that was absolutely true. The other thing they said that I didn't anticipate was, and you don't bring us the data that we want. We're not really interested in how these procedures perform in tertiary centers. That's all your data. What we want to know is, how do these procedures perform in standard clinical practice, right? Just in hospitals across the country where we're paying for this, how does it work in those places? And that is data that we didn't have then, that to a large degree we don't have now. But you know, it is in fact an important question. Now, we've made a lot of improvements since that point in time. We've begun a much wider use of patient-reported outcomes in a variety of ways. It's not perfect, but it gives you, to some degree, the view of the patient. We have done at least a small number of really high-quality studies by the standards of other specialties. You know, RCTs, the sports study is probably the best example. ASLS is a NIH-funded study in deformity, but the reality is these studies are incredibly expensive, and it's pretty unrealistic that we're going to spend $20 and $30 million for every question that we want to answer. The other thing that's happened that's really advanced the science is multi-center databases. So you've heard discussion about ISSG, a harm study group. Those are groups that have brought together surgeons and have produced really good data sets. They are very intensive, work intensive, and somewhat cost intensive to collect that data. And so they've generally been around deformity, where the hospitals and the surgeons and industry sports to some degree, you know, is sort of dedicated to taking care of these deformity patients, less so in degenerative disease. And then there are administrative databases. I think Sig mentioned NISQIP, which is probably the best version of that, right? 3.5 million patients, that starts to be real data. And there is a lot of manpower to collect that data, but the way they've been able to manage to do that is they collect it in a very narrow time slot. So, you know, mostly just 30 days post-op. And that is important data. It's important data around perioperative stratification, but there's a lot of things we want to know in spine that just aren't over by 30 days. We also have some really significant shortcomings in our data. We don't have consistent quality of data. There's lots of instances where there's holes in the data, or we have data up to a short time frame, but you know, not more long-term data. We get out to 3 months or maybe to 6 months, but we have a lot of trouble collecting data like to a year or 2 years. And then often we have just focus on narrow pieces of data and not the wide breadth that lets you start to do things like the AI type of assessments that Chris talked about. We don't necessarily have representative data, right? We talked about having data in standard clinical practice, but that's still not what we have. What we have by and large is data in tertiary centers. And whether that's better, worse, or the same, we really don't know the answer to that question. We also don't have timely data, right? For most things, if we're doing a new procedure, if you're going to collect data on that procedure, to really do that takes several years, and then it's several years to get things into publication. So if you decide I'm going to try a new technique or procedure, and you're going to wait to see what the data looks like on that, right? You may be on to the next procedure before the data is even published on the procedure you did previously, because there just aren't that many things in spine that we do consistently without changing what we're doing for 5 and 10 years. So, you know, those are challenges. And one of the ways to try to circumvent or do better than that is to use registry data. And the first real and best spine-based registry approach was started by AANS, and was called QOD. It was an effort to be a registry across all of neurosurgery and to be available across all of neurosurgery. It was actually also offered to orthopedists. There weren't too many participating centers, but we were one of them. And it was supposed to be a platform that would really allow broad data collection. QOD has done a lot of good things. It's accomplished some of its goals and not others of its goals. It's the first registry where there was standardized collection of patient-reported outcomes, and it made really excellent progress in this regard, and has, you know, sort of set a standard where more and more people, both in terms of publication, but just in terms of running your practice, have started to look to patient-reported outcomes as a piece of what's important. It was much better than anything preceding it for diagnostic delineation. Rather than just, we understand spondylolisthesis, we understand scoliosis, but everything else is a mud puddle that we're going to call degenerative disc disease. It started to break out different diagnoses in terms of post-discectomy instability, in terms of mechanical collapse, things that might behave differently in terms of outcomes. The goal to facilitate a real nationally driven quality improvement process, that is to be accessible to all, I would say it didn't meet that goal as much as sort of was hoped. But in terms of novel scientific research and being able to look at certain problems really among a small group of the centers, about 10 to 20 centers, that added resources to the underlying database and made it an effective research tool, I think that exceeded people's expectations, and QOD did that tremendously well. Parallel to that, there was an effort in orthopedics, not in spine, but in joints, to build a registry for joint replacement. And AAOS really approached this differently. This wasn't basically a physician-driven process. This was an administrative-driven process done primarily at the hospital level to meet and accommodate requirements for government paying programs and for centers of excellence. And they built it differently. They looked to build the ability to collect a automated data set. So this was something within the hospital IT where it would draw a certain set of data around hip replacements and knee replacements, and on a monthly basis, any patient enrolled in that program, their data would be uploaded to the registry. So it had the power of automation. It was much more accessible for hospitals, so it's in 1,400 hospitals around the country, more at this point. So really broad representation, even in ASCs and small hospitals. And it looked to meet performance measure needs, but and to be a quality improvement program rather than a research activity. It was effective in that it was very broad. It didn't collect patient-based outcomes. One thing it did collect that hadn't been in any registry before was implant detail. So a very different kind of effort. And when we look to try to expand the ability to have a national registry, this looked like a real natural collaboration for several reasons. First of all, the spine is more or less 50% in orthopedics and 50% in neurosurgery, and the capabilities that AANS had developed and AAOS had developed were tremendously complementary. So over a couple-year period of time, there was a lot of discussion of bringing these resources together. Chris Shaffrey, who you're going to hear from in a little bit, was AANS president at that time and had a lot to do with making this happen. I think there were a lot of skeptics that said, sure, that makes sense, but it's just never going to happen. But in fact, it did. And in 2019, the two organizations agreed to collaborate on this National Quality Improvement Registry. So this is the basic structure. The board of directors of each organization oversees it. There's an executive committee. There's committees for data operations and data use. And what rolled out in 2020 was two modules, one a degenerative cervical module and one a degenerative lumbar module, sort of looking at what's broadly done in spine surgery. There are a significant number of centers that are enrolled and contributing data at this point. This is a little bit of an old slide, but it's probably up at about 250 centers. And the structure, there's some important pieces of the structure. So one is that it enrolls all eligible cases. So one of the concerns about registry is a bias based on picking what cases want to get enrolled. But the way this works is if your hospital participates, a certain surgeon can choose to participate or not, but if you're participating, so your surgeon identifier is one of the group of identifiers that's utilized, then any case that's a degenerative lumbar cervical case meeting the CPT and ICD-9 qualifying characteristics, all of those cases are enrolled. So there's no choosing which case gets enrolled or doesn't get enrolled. So it's all eligible cases. The procedural data that gets fed in an automated way repetitively to the registry is the demographic data, it's the procedure data, it's the implant data, and then because each time this patient hits the system, it's complication data, it's readmission data, it's reoperation data, and post-op complications. It'll also feed in comorbidities and things that allow you to do risk stratification. And that is in each given hospital standardized. So up till now, there isn't a sort of physician burden for this. But there will be, right? Because for us, we need patient-reported outcomes. It's not good enough just to have the automated data, which is what's really in the hip and knee registry, where all they're looking at is revision rate. The other thing is there's what's called Vanguard centers, where there's an operative form that more or less mimics what you would do in the timeout, where you talk about the details of the procedure, what exactly was done, what levels were operated on, where cages were put, and that's a form that's at some point becoming automated within the EMR. It'll be first in Epic, and this will be more work than will be done at some centers, but it will, as Michelle said, produce a data set next to the standard data set that gives much more robust data for comparison. One of the big elements is patient-reported outcomes. That's a requirement of the registry because it's the standard for how we're judged. We don't really believe that sites that have never collected patient-reported outcomes are going to get this on 100% of their patients. So at the beginning level, at the standard level, we're looking for baseline and 3-month outcomes on 25% of the enrolled patients. We think that's a realistic goal. We'll see how that plays. And then the registry has the capability of collecting outcomes up to any point in time, and whatever outcomes a given site collects from legacy measures to promise to other measures along those lines. Another really important element of the registry is integration with Medicare. So the registry is the only ones that have a relationship with Medicare where theoretically quarterly, in COVID it hasn't quite been quarterly. The registry is aligned with the Medicare data set. That means that on a patient identified level, Medicare sends the registry the data on the patients within the registry. The registry doesn't send anything to Medicare except the names and identifiers, and they send the Medicare data, which means you get the robust risk stratification of all their Medicare record back to 2012. It also means that if they have a procedure one place and a readmission another place, that patient isn't lost to the registry. So it makes it much more robust for longitudinal follow-up. The data is fed back to surgeons and hospitals through a dashboard that allows a comparison to regional and national benchmarks. That allows surgeons to look at, in much more real time, the effectiveness of one procedure they're doing versus another for perhaps the same problem. It also will be a feedback mechanism for sites to pull off their data for research purposes. So what are some of the key concerns, right? So whenever I give this talk, there are certain things that surgeons worry about very consistently, and one is governmental access. If you're dealing with Medicare, does that mean they get your data? And so one important feature of this is nobody gets your data. Nobody gets any individual surgeon's data except that surgeon. You get compared to de-identified national databases, but Medicare doesn't even get a de-identified national database. That's all held within the registry, and in relationships that we've built with outside organizations, like, let's say, payers, if you're going to qualify for a program that identifies quality or that avoids pre-authorization, the registry will certify that you meet the criteria, but your data is never given to any third party. Another concern is competitive surgeon data, right? So if you're in New York and you're compared to a regional benchmark where there's 30 spine centers, right, that's pretty de-identified. In small markets, you can only compare to national benchmarks because we couldn't let data out letting you compare to regional benchmarks in a place where there's 3 centers or 2 centers. So there's a lot of effort, and this has been vetted through 10 years of AJRR, making sure that surgeon data is well protected. There's a lot of value of this for surgeons and sites, QI in real time, certification for quality programs, potentially the ability to bypass pre-authorization burdens, data research access for centers for whom that's important, and it has MOC qualification for both neurosurgery and orthopedics. At this point, it qualifies for Joint Commission Center of Excellence, and it used to be you just had to be in a registry. Now you have to be in ASR to qualify for that. So there's an increasing build of benefits for participation. The strongest early achievement has been with regulators and payers, buy-in from major health systems, a lot of interest from organizations like FDA to potentially use this as part of post-market surveillance, because it is potentially a way to collect granular data at scale, which is something we've just never been able to do effectively thus far. There's also challenges. I mean, I think we looked initially at how it was pretty easy to do in hips and knees, and we just do it exactly the same in spine. And, you know, not surprisingly, probably to anyone in this audience, spine is a lot more complicated, right? In hips, there's one diagnosis and one implant, right? That's not how our data looks. So there's the complexity of the data at every level is a challenge. It's a challenge for the IT build. I would say it probably takes the IT person at the hospital a good 4 to 6 weeks to build this, right? Once it's built, it runs in an automated way with very little effort, but the IT build, it will, the burden will come down some as more and more hospitals have it, and other hospitals can utilize what's been built previously, but the differences between hospitals and how their data flows is pretty dramatic, and it's clearly an effort at each place we build it. That's why there's such a critical role for surgeon champions, because when there's someone at the hospital encouraging the person who's the programmer, we need this, you know, and this is valuable to us, it really moves the process along. Once we start analyzing the data, we're going to find, you know, challenges in terms of the complexity of analysis, right? Because The same procedure, different surgeons code it different ways. And, for each diagnosis, different surgeons do different procedures. And there's multi-stage procedures, and there's multiple surgeons in a single procedure in some places. And the implant, constructs which we get implant lot number identification on every implant that's implanted, right? So incredibly valuable data, but a tremendous amount of data. And for PROMs, which is hard to collect, right? Some people collect them at a hospital, and some people collect them at their office, and some people collect them over the internet. So pulling all that together, is complex and will continue to be a challenge. We also need longitudinal data, right? We care about 1-year outcomes and 2-year outcomes and long-term outcomes. Just to touch a little bit for a second on deformity, because that's one of our topics. I don't see this ever being a way to look at major structural deformity. I mean, who knows, way down the line. That's very complicated, and that's something that's going to be managed in groups like ISSG that have the bandwidth and the drive to do all the analyses for those complex radiographic type patients. But I do see this as a way to look at degenerative deformity, the 25-degree curve, that the problem is stenosis and you have to deal with the curve in order to manage the stenosis. I think that's a potential reasonable next step for this kind of data collection pathway. I'm all right still? Okay, and I'll just kind of give you an example. This is a study that we did with HCSC, which is a big national Blue Cross company. So it's an administrative study. It's an administrative data, but what we looked at is we wanted to see what's the value of weight-bearing x-rays in patients undergoing spine surgery. So we looked in their database at any patient who had any spine procedure, right? So they had discectomies, they had short fusions. These weren't deformity procedures. But we could see in their database if the patients ever carried a diagnosis of deformity. So a lot of these were patients that had been told they had scoliosis at one time, but that's not what they were being treated for, right? And then we had more than 5 years of follow-up on the patient. So what we were looking for is, did they have revision procedures? And we looked at those patients who had an MRI as their only study for their operation. And 5 years down the road, 40% of those patients had been reoperated on, right? And then we looked at the patients where all that was added was some weight-bearing radiograph. And the revision rate at 5 years went from 40% to 10%, right? For the price of an x-ray, right, you save 30% revision rate, right? Now, I don't know exactly why, because administrative databases don't give you granular answers, but it certainly can guide you into, my guess is you are picking out surgeons who paid attention to, the overall patient. But in any event, whatever it may be, the role of these big databases is going to let you know what's the right question to ask. It's not going to give you granular answers like you might get out of an ISSG database, right? But nonetheless, in the huge breadth of what we do in spine surgery, that's an incredibly important thing for us, because to apply something like AI, you need granular data at scale. And I would argue that even though some of these presentations we've seen today have been great, for the vast majority of what we do, we don't really have granular data at scale. And we're going to have to find a way to collect it to make all these other techniques really valuable. So thank you very much.
Great talk.